about the Netherlands, because the Netherlands in my slides looks very good, but with regard to access and quality, so I think that it would be relevant here. And one thing you hear about the U.S. system is, well, it's an expensive system, but you can get care when you want it. And I think it's a little bit more nuanced than that. In this slide, it doesn't really look that way. On the left, you look at, can you get an appointment the same day? And actually, the U.S. and Canada tied for worst here. 26% of people could get it the same day. It's an unusual view of queuing, but it's an interesting one, I thought, nonetheless. On the right is, do you have to wait 6 or more days to get a doctor's appointment? And here on the U.S. at 23%, it actually is worse than average. So if you're looking at these sorts of weights, getting something the same day or getting an appointment with your doctor, the U.S. actually doesn't look so good. Where the U.S. looks better is in this next slide, and this is where the lack of colors is going to be a little bit of a problem for you here. I think what I'll do is just talk with you. Can I stand up and show, or can they can see? Okay. The good color is the blue. That's the 1 month. And so in the U.S., that's the bottom, it's the right side. 53%, I didn't tell you what this was, this is waiting time for elective surgery. So 53% of Americans wait less than a month for elective surgery. That's much better than Canada, where only 15% get it within a month, and the UK 25%, but actually worse than Germany. I thought that was quite interesting. And if I also showed you waiting for a time to get specialist services, you'd also see the U.S. does very, very well compared to Canada and to the UK. Kind of everybody knows that, but actually it does worse than Germany. So what that tells me is you can have a system with government-controlled universal coverage that does not lead to queuing, because Germany actually has better queuing statistics than the United States, but still the U.S. does actually look pretty good with regard to this one aspect of access. And then very quickly with regard to quality, I just want to talk about the right side here. The infant mortality rate in the U.S. is far higher, pretty much double the other countries. Part of it has to do with the healthcare system. Part of it has to do with other factors in the U.S. This is potential years of life lost due to diabetes per 100,000 population. In the middle, we have the OECD median. You can see the U.S. is more than twice the median. It's the worst. And if I could take almost any health malady and put it in instead of diabetes, like heart conditions, and you'd get the same pattern that we, being an American, have more years of life lost than any of the other countries. This is defined as deaths before the age of 70, I believe, adding up all the years people died before the age of 70. So the U.S. is actually looking pretty bad with regard to quality. And I'm not going to spend much time on this slide, but this is the analogous, my access slide, it's quality. This is basically 4 different quality problems: getting the wrong medication or dose, medical mistake in treatment, incorrect diagnostic lab results, or delays in dealing with abnormal results. If you just look at the bottom row, any of these problems, the U.S. had more of these than any other country, although Australia and Canada aren't looking so pretty here either. And readmissions after hospital, or if you go to a hospital, being readmitted to the hospital, or having to go back to the emergency room. Again, the U.S., the worst, although Canada and here the Netherlands is the one place that did poorly, also did poorly. So nothing is looking good with regard to the U.S. with regard to quality, even though we spend twice as much as any of the other countries. And this last thing is a ranking that the Commonwealth Fund did, putting together lots of different measures. I don't have the definitions with me, but what they did is they ranked 6 countries: Australia, Canada, Germany, New Zealand, the UK, and the U.S. The U.S. came in last in almost all most of the quality rankings. Canada came in 5th in most of the rankings. You know, it is a porous border, as Tony said. So anyway, that's the context for the U.S. reform. These data have been out now. We knew that we needed to make changes. So what I'm going to spend most of the rest of my time is telling you about what it is that we just passed. I don't have that many slides, but I have the key elements for you. It mainly has to do with insurance coverage. We're not going to get rid of our uninsurance problem. We're going to reduce it by about 60%. We're going to move from about 48 million uninsured people to about 21 million uninsured people. And it's being done in 4 ways. First of all, for people who are uninsured, we're going to give them subsidies. We're going to give more money to people who are poor, so they're income-based subsidies. We're requiring employers that have more than 50 employees to offer insurance. We're requiring people to buy insurance. That's called an individual mandate, something that the Democrats, the left, didn't really care for a long time ago, but they were the ones behind this, and the Republicans, the right, were against it. So we really had a big changeover in the last 20 years politically. And Medicaid, this is our coverage for poor people. It was very haphazard until now, but is a big expansion, as I'll talk about in the next slide, in coverage for poor people. There are mechanisms that are both private and public. The private mechanism is each state, each of the 50 states, is going to create what we call an insurance exchange. It's sort of a brokerage where all the insurance companies put themselves up, and uninsured people and people who work for small employers that don't offer coverage, they'll buy from this exchange. There's a lot of debate, should it be a national exchange or 50 state exchanges, and I would have liked to see a national exchange, but that's not the way it went. On the public side, as I said, a big expansion in coverage for the poor, Medicaid. So a little bit more detail. So the subsidies are up to 400% of the poverty level. So if you don't have insurance from your employer, or you don't have an employer, and you have up to 400% of the poverty level, for a family of 4, this is like $80,000 a year. So subsidies will be going to people who are definitely middle class, well into the middle class. You'll get some sort of a subsidy, but it's on a sliding scale. The closer you are to that level, the less subsidy you'll get. Now, Medicaid, again, is our program for poor people. It used to be that some states had terrible coverage and some had pretty good coverage. And really remarkable thing about this reform is every state is going to have good coverage. Every state, up to 133% of the poverty level, people will get coverage. In a state like Texas, you had to be at 20% of the poverty level before. Basically make almost no money to get Medicaid. Now it's above the poverty level. So that's one of the really key aspects of the reform. But keep in mind, most people think Medicaid isn't as good as private insurance because it's hard to get access to a doctor in the doctor's office. You normally have to go to a clinic. There's this individual mandate. If you don't have insurance, you have to buy it, and if you don't, you're penalized. The penalties are $700 for an individual and $2,100 for a family, so it'll pay to buy insurance. If you're an employer with more than 50 employees, you have to provide coverage or you're penalized. You're penalized about $2,000 per employee. This is, if I had to pick one slide that I think is most important, it's this one. In the United States, currently, if you have a history of illness, you cannot get insurance unless you work for a big employer. Just cannot do it. Everything is changing. Under this legislation, insurers can't turn anyone down if they have a history of illness. They can't terminate coverage. They have to renew coverage. They can't charge sick people more. That's the key thing. They can't charge sick people more. They can charge older people more than younger people, but that's it. And they have to return at least 80% of premiums in the form of health benefits, although already the insurers are going through a lot of shenanigans and defining what a health benefit is. So there's a lot of debate about that. But insurers, cynically, insurers were in the business of not giving health insurance in the United States. That is changing. Insurers are going to be required to give insurance to people. I really think the only gaming that can happen going forward is refusing to pay a claim. So we might see that happen. There are a few what I would call baby steps that are going, and Tony mentioned some of this, towards quality enhancement. We're establishing a national office to look into comparative effectiveness research. Doesn't mean we're using it yet, but we're talking about using it. We're establishing pilot programs to move away from fee-for-service to bundle payments, and to have these bundled payments be shared among hospitals and doctors and post-acute services. So we're trying to get disparate organizations to join together for the purpose of reimbursement so we can pay a bigger bundle than the individual service, and that will over time help reduce churning. It's going to take a long time, but we're moving, and I think that's a really positive development to try to move somewhat away from fee-for-service. And also where Medicare is going to, and Tony mentioned this, to start paying hospitals based on their performance with regard to quality, and hopefully doctors and nursing homes later on. Just a couple more slides. Where's the money coming from? It's going to cost $1 trillion over 10 years. And where is it coming from? One of the main sources is taxing the wealthy more. This really is perspective B that Tony was talking about. People make more than $200,000, families making more than $250,000 are going to have to pay a bigger payroll tax. Right now we pay a payroll tax for Social Security or pension when we're old, and Medicare, health insurance when they're old. Wealthier people are going to pay a bigger payroll tax, and they're going to pay a tax on their investment income. So that's where a lot of the money's coming from. A little money's coming from something called a Cadillac tax. Cadillacs, fancy old American cars. If you have a really, really, really expensive health insurance plan, the employer is going to have to pay a surcharge. But it has to be so, this won't happen for 10 years, for 8 years for political reasons, 2018, and the plan has to be worth more than $10,000 for an individual and $27,000 for a family. We're not going to raise much money from this, but it provides an incentive for employers not to have overly generous health insurance plans. We're going to reduce payments to Medicare managed care plans. That's sort of a boring U.S. thing I won't go into. If in the main part of our Medicare program, if spending goes up too much, there's going to be a national board that's going to tell Congress, here's how you can reduce the spending. So there'll be some mechanism to try to deal with spending if it's too high. And I put in this last one because it's interesting. There's a 10% tax on indoor tanning services. And there was a lot of opposition from the tanning industry, but it did not prevail. And so we have that. Indoor tanning is bad for you. Just 2 slides of analysis. Is the U.S. moving closer to Tony's system-wide perspective B? I think with quality, there are some baby steps that I mentioned with regard to cost effectiveness. I think that even more important in the short term are these pilot studies to try to move away from fee-for-service. And what's really important in the short term is if our Medicare program, the program for the older and disabled people, really starts linking payment to quality performance. With regard to access, we're moving to perspective B, system Y. We're reducing most of our uninsured, and all of our poor people will be covered, and even people who are near poor will be covered. Different story with costs. We're not doing hardly anything to control costs. Politically, it was impossible to pass any legislation that controlled costs, and I was okay with that. When we passed Medicare in 1965, there were no cost controls. We put them on later. We're going to have to put them on later this time. Interestingly, there's more reliance on private insurance rather than less, because more people will be insured, and there's no public option. There was a lot of talk about having a public option to sell insurance, basically a government insurance plan. It went nowhere politically. As a result, there's no big purchasers. There's no monopolistic power the way that, say, Canada has. So we're not going to have the ability to control costs the way that Canada does. And we're scared of supply-side controls in the United States, controlling the number of doctors, hospitals, technologies. There's really none of that. Eventually, we might get a little bit through cost-effectiveness, but it's going to be a long time, and it's very un-American. So I'm going to have some kind of boring political questions on my last slide, and then Carolyn's going to give you some deeper political questions. And actually, Tony independently came up with some pretty similar ones here. First of all, is our legislation going to be repealed? It's not going to be repealed before 2012. That's when the first Obama administration ends. He will veto anything that repealed it. If the Republicans win in 2012, if they win both sides of Congress, it's conceivable it could be repealed. Probably it won't be, because I think people will enjoy some of the benefits. There's an individual mandate. Will this be ruled unconstitutional? We don't know. This public option, are we always going to have government not compete? A lot of us would love to see government compete against the privates. Maybe that will be resurrected. Will we ever do something about the 20 million uninsured Americans? I don't know, but that's still a big ugly thing about the legislation. So many people are still uncovered. The U.S. will still be an outlier. And will we ever get any meaningful cost controls? Not for a long, long time. But as I say, I don't think that there's no way this legislation would have passed if it had any meaningful cost controls. Thank you. All the thinking.
Pay no attention to what you've heard about how this is going to be the analytic wrap-up. That's it. Yes. Okay. I am indeed the only non-economist on the panel, probably the only non-economist in the room. So at least what I will give you may be the sort of analysis that you don't usually hear. That will be the extent of my ambition. I want to, and we did, as Tony said, conspire a bit beforehand about the order of presentation, and I really want to build on what my two colleagues have already told you, and to speculate on whether the U.S. will continue to be the exceptional case that it has presented. Those of us who are interested in comparative health policy have always seen the U.S., well, at least since the 1960s, as the great outlier, the biggest example of a system without universal coverage, and indeed a very large example, accounting for about half of all total health expenditure in the entire OECD. So it may be an outlier, but it's an outlier that's very hard to ignore. Well, why have we not seen universal health care in the U.S. until now? And as has been pointed out, it's not quite universal even yet. There are essentially three hypotheses, and I will build on Tony's presentation to present hypothesis one, which is the U.S. is a perspective A culture. You get the health system that your value system will support. Or at least perspective A has a heavier weight and has always had a heavier weight politically in American life than has perspective B. Perspective A, you'll recall, being the more individualistic and market-oriented of the perspectives. There's a second and somewhat related hypothesis, which is that the structure of interests in the U.S., and in particular the power of private insurance, is greater than it is in other countries. And that has established the constraints on what can be done in terms of universal government-sponsored coverage. And then there's a third hypothesis, which is that there are certain moments in history, in any nation's history, in which there's an opportunity to make big change in healthcare. It's very, very difficult in any nation to make big change in healthcare, big change that changes the balance of power in the healthcare arena among, in particular, government, private finance, and healthcare providers. Or big change that shifts the mix of instruments, reliance on a hierarchical command and control mode as opposed to a more market-oriented mode, as opposed to a professionally oriented collegial way of making decisions. We see different balances across nations, and making changes in that mix and in that balance is really hard because interests grow up around it. But at particular points in history, it is possible to make such change, and in those moments, politicians make strategic decisions. They have to make strategic decisions. The decisions they make are crucially important because they set the parameters going forward until the next window of opportunity. And the changes, the decisions that they make, the frameworks they put in place, then go on to shape public opinion and the structure of interests. Okay. Why am I not
Try
moving forward?
that one there.
Ah, there we go. Okay. Well, as you may have expected, given the amount of time that I spent on hypothesis 3 on the last slide, that will be my argument, that it is these strategic decisions that are made in important windows of opportunity that really shape healthcare systems. And I'm going to illustrate that by comparing Canada and the U.S. As Tony pointed out, in their histories, Canada and the U.S. have had very similar healthcare systems until the 1960s, and I'll come to that in a minute. Currently, however, they look very different. Canada has a so-called single-payer system for physician and hospital services, only for physician and hospital services, which are funded by government through general taxation. Else, other services function in a much more mixed market. Some are subsidized, some are not. It varies across provinces. The U.S., of course, has had government health insurance for the elderly and the poor since the 60s, and essentially a private market for the rest. Well, let's just run through the 3 hypotheses as to why these differences pertain between the 2 countries. You could argue, well, Canada is a prospective B nation. It is a so-called kindler, gentler nation, as Canadians have often referred to themselves, particularly looking across the border south. And to some extent, as we'll see, that's true. But with regard to health care, in the moment in which the current systems were established in the 1960s, that's when Canadian Medicare was established, that's when the U.S. version of Medicare was established, Canadians were no more supportive of state involvement than the U.S. was. And fortunately, there were polls done, fortunately for us scholars, there were polls done during the 60s in both countries. The questions weren't exactly the same because essentially they were framed by the policy debate at the time. And Canadians and Americans were asked about the options that had been put out there by politicians. So Canadians were mostly asked about government involvement for health insurance for everyone, for the entire population, and Americans were generally asked about government involvement in health care for the elderly. Nonetheless, Canadians were, if anything, more opposed to a compulsory program than the U.S. Canadians tended to favor a more voluntary voluntary program based on private insurance subsidized by the government, and didn't look all that much different from Americans. So there, I think you can see the non-colors there, but at least the shades of gray. This is in 1965. You can see that Canadians actually favored voluntary over compulsory government programs. The U.S. actually favored compulsory over voluntary programs. Now, however, 40 years later, healthcare is one of the few areas in which Canadians and Americans differ with regard to state involvement. Again, fortunately for scholars, there's an international survey called the International Social Survey Program, which is a collaboration of a large number of countries. It's up to over 40 now. And they all agree to add to national surveys, usually annual surveys, a common module of questions about values primarily. And looking at the values about state involvement from the 2006 surveys, we see some interesting results. And I'm drawing on some data here from my colleague Richard Johnson of the University of British Columbia. And I've manipulated it myself, so he bears no responsibility for this slide. What you will see in the following slide is the difference between Canadians and Americans with regard to their approval of government involvement in a number of different areas. And you're going to see where Canadians are more approving, you will see that toward the right side of the graph, and where Americans are more approving of state involvement, that will be toward the left side of the graph. And this is more or less what it looks like. There are two measures here. One is just the difference in the mean approval or the average approval, and the other is what I've called net strong approval, which is if you take everyone who strongly favors government involvement and subtract everyone who strongly disapproves of government involvement in that area, you get the net strong approval. These slides show the difference between the two countries. Okay, they are not absolute values, they are the difference between the two countries in these measures. And so you'll see that Canadians are more supportive in areas such as reducing inequality, income inequality, and health care. But in most areas, I'm pointing at this screen, why am I pointing at this screen? In most areas, you'll see that Canadians and Americans only differ by at most 5 to 6, 7 percentage points on questions such as aid to the elderly, aid to the unemployed, protection of the environment, provision of housing, ensuring jobs for individuals. Where Americans are more supportive than Canadians is in areas like student aid and controlling prices, surprisingly enough, and where Canadians are more supportive is in reducing income inequalities and, of course, health care. So from a period of of similarity in the 60s, Canadians and Americans have now diverged in terms of whether or not they think government involvement in health care is a good idea, as they have each become accustomed to the systems that were put in place in the 60s. So essentially, what we observe in public opinion, the relationship of public opinion to public policies, is a cycle, I would argue, or an iterative iterative relationship in which politicians put ideas out there. The public expresses through polls and focus groups and various other measures priorities among those, attitudes about the options that have been presented to them. And politicians respond and shape their objectives, their options accordingly, and feed those back, and they get more feedback from public. They finally enact policies, and then the population begins to experience those policies in lived terms and form attitudes and feed that back to politicians, etc. So we can't assume that these big changes in policy are driven by public opinion. Public opinion plays a role along the way, but it doesn't drive.
Just so you know, you'll have to click to get the point.
Yes, right?
And that's all. You're halfway through.
Okay, thank you very much. I'm just where I want to be, fortunately. Into this cycle can intrude at any given point what Harold Macmillan famously termed as the most difficult part of his prime ministership, events. Dear boy, events. So those events can intervene to affect both politicians and the general public. Hypothesis 2, so that was hypothesis 1, is Canada a perspective B country as opposed to the US being perspective A? Well, maybe now, but not so much in the 60s and not with regard to health care. Hypothesis 2 is that the infrastructures in the US are more complex. Well, again, I'm going to take you back to the 60s. This was not true in the 60s. Canadians and Americans had identical healthcare delivery systems, fee-for-service private practice, voluntary hospitals, identical proportions of the populations covered by private employer-based insurance, insurers evenly divided between for-profit and not-for-profit carriers. The insurance industry